Dr. Puricel from, I think, from Fribourg, who will take over the initial role of Mario Toni, and I think still going on the antiplatelet therapy in the periinterventional situation. And I think for some patient we can offer today a bridge solution for preparing the patient for the surgery, reducing the bleeding risk. Please, Dr. Puricel.
Yes, thank you very much. As you mentioned, I come from the University and Hospital of Freiburg, and I'm going to talk about antiplatelet therapy in the periinterventional situation. I don't get any money from the industry. I did went out on a social event last night, given the early time of the presentation. How am I to introduce the subject at hand? You all know that with the advent of DES, there was a decrease in restenosis, but an increase in stent thrombosis, which of course warrants efficient and prolonged dual antiplatelet therapy. The main drugs have already been presented and discussed. You have the thienopyridines, which are irreversible and which bind to the aforementioned P2Y12 receptor. And then, of course, you have ticagrelor, which is a reversible binding. And there is a direct antagonist of ticagrelor on the way. I think it's called Medi 2514, which we'll soon hear about at conferences. So when you look at patients that just underwent PCI and that need dual antiplatelet therapy, it is presumed that they are at an increased periinterventional bleeding risk. The ESC guidelines on myocardial revascularization talk about, for instance, about 10% of NSTE-ACS patients need to undergo CABG during their index hospitalization, so they need dual antiplatelet therapy, but they are in an increased bleeding risk. And so the authors postulate that ischemic and bleeding risk must carefully be evaluated and weighed in these challenging patients. You can see here, so there is a risk of thrombosis. If there's a high risk of device thrombosis, they say you rather continue dual antiplatelet therapy. If there's few risk of thrombosis but a high risk of bleeding, you should rather stop both antiplatelet drugs. And this is especially true, what they say, for semi-elective and urgent cases where you have to perform a case-by-case decision. And I was asking myself, well, if we stop dual antiplatelet therapy in these patients, what is the thrombotic risk that we incur? If we don't stop these drugs, what is the bleeding risk that we incur? And what can we do in order to diminish both? First, I will focus a little bit on the bleeding risk and the thrombotic risk in clopidogrel, which is second-generation thienopyridine. And we have a lot of data. There were basically two big meta-analyses which showed that if you expose patients to clopidogrel before CABG, then there is an increased risk of death, reoperation for bleeding, blood loss, etc. And also, there is increased mortality if you don't stop clopidogrel 5 days prior to your intervention. However, when they look closer at patients with same ACS status, that means patients that had an acute coronary syndrome, there was no difference in mortality or in perioperative myocardial infarction or stroke. You can see here even that there was a trend towards decreased myocardial infarction rates with patients that were on clopidogrel less than 5 days prior to their intervention. Now, the new drugs, prasugrel, what is the current evidence that we have? It, of course, arises from triton-timi 38, and in a subgroup of CABG patients, prasugrel was associated with a low rate of death compared with clopidogrel, but there was an increase in observed TIMI major bleeding. Unfortunately, the authors of this subgroup analysis did not really provide when the drugs were stopped in the individual patients, so we don't know if patients that received dual antiplatelet therapy up to a couple of days before the intervention are at an increased bleeding risk compared to patients in whom prasugrel was stopped 7 days before the intervention. And you can see here on this graph the different groups. Clopidogrel in blue, this is the individual patient data points, and for prasugrel in green. And you can see that there is a very low mortality with prasugrel and a higher mortality with clopidogrel, especially in these patients in whom clopidogrel was stopped less than 5 days or 4 days prior to the intervention. What we also know is if you discontinue patients on prasugrel, more than 57% of patients will return to their baseline platelet reactivity by day 7, and this is the reason why current guidelines proclaim that you should stop prasugrel 7 days before the intervention. Ticagrelor had the big Plato study, and they also had a sub-study or a post-hoc analysis in which they did a very lovely thing. They created a table and they showed the days of ticagrelor discontinuation prior to CABG and the percentage of CABG-related life-threatening or fatal bleeds. And you can see that if you stop ticagrelor early, then you have about a 30% bleeding rate. But if you stop it one day or on the same perioperative day, then you have a very high bleeding risk of about 65%. However, there was no significant difference between bleeding in patients on ticagrelor or patients on clopidogrel for all of these subgroups. You can see that they also plotted cardiovascular death for patients on ticagrelor and patients on clopidogrel. And you can see that there was a significant reduction in postoperative cardiovascular death in patients that took ticagrelor, especially in those that discontinued the drugs 2 to 4 days prior to CABG. And so these are the current guidelines on NST-ASC, authored by Professor Roffi from Geneva, where you can see what they propose here. In stabilized patients requiring CABG who are on DAPT, discontinuation of ticagrelor and clopidogrel 5 days before and prasugrel 7 days prior to surgery should be considered. As I told you, I was asking myself, why do they recommend that? It is based on the Plato sub-study about ticagrelor, which I briefly introduced just before, and on the 2 meta-analyses on clopidogrel. There is no information on prasugrel, unfortunately. Now, there was another position paper which was published in 2014 and which addressed the specific question of management of antiplatelet therapy before CABG. And so you can see that they recommend to pursue aspirin in patients with low bleeding risk, in Jehovah's Witnesses or patients that cannot be transfused. You should refrain from continuing aspirin. And there again, the same recommendations with regard to the thienopyridines and the ticagrelor. And then there's this rather interesting table where they tell you a little bit what you can do considering the patient's thrombotic and bleeding risk. What has already been discussed is that if you have high risk for thrombosis, bleeding, you should really talk. The heart team should discuss each case individually. Only if thrombotic risk is low and bleeding risk is low, it is advised to follow the guidelines without a prior discussion of the heart team, I think it still makes sense to discuss every patient. And so we talk here about the thrombotic risk. I've shown you a little bit data pertaining to the bleeding risk. And I was asking myself, what thrombotic risk do we really incur if we discontinue DAPT in patients that had just recently been stented? And if you look a little bit at some old studies, on some old trials which mainly evaluated first-generation DES, and we know that first-generation paclitaxel and sirolimus-eluting stents were associated with relatively high thrombotic risk. But for instance, in the CURE trial, there was a non-significantly decreased MACE rate in patients on DAPT up to the day before surgery compared to placebo. The basket late investigators from Basel, they showed that there's an incidence in stent thrombosis of 2.7% in patients who prematurely, at the time being, interrupt DAPT after 6 months. Then if you interrupt that after 30 days after your stent placement, you have a very high death rate. 7% of patients die who interrupt DAPT 30 days after, compared to only 0.7% of patients who do not discontinue dual antiplatelet therapy throughout the first year, which is very interesting. In this study, the first event, the first death, occurred 3 months after dual antiplatelet therapy discontinuation. So if you think about surgery or about CABG, where you have to discontinue the drug during a couple of weeks max, there is some interesting point here to be made. Then there were 2 other big studies. For instance, here, this publication by Jacobo and colleagues in JAMA, they found that premature discontinuation of antiplatelet therapy, so clopidogrel and aspirin both, was associated with a 90-fold increased hazard in the occurrence of ST in their patients. And if you discontinued dual antiplatelet therapy within the first 7 days, this hazard was increased 152-fold. So I think there's strong evidence, at least in these patients, that there is some major thrombotic risk. But if we look at newer generation drug-eluting stents, especially second generation durable polymer everolimus-eluting stents, our colleagues from overseas, Roxana Merum from Columbia University, published a very interesting studies in 5,000 patients. You can see here. So this is patient discontinuation, discontinued because they didn't need it anymore on medical advice. Interruption, these were patients that needed to interrupt DAPT because of a surgery. And disruption, these were patients who needed to interrupt dual antiplatelet therapy because they bled or had any other complications. And you see that patients in whom dual antiplatelet therapy was interrupted because of an impending surgery did not present significantly more definite or probable ST and did not die more frequently from cardiac causes. So that raises the question whether or not this thrombotic risk can really be postulated with these new devices that we have now since a couple of years. So I've shown you that there is excessive bleeding risk with dual antiplatelet therapy and CABG, that there seems to be increased thrombotic risk, especially in first generation devices, which are fortunately not used anymore. Probably not such a high thrombotic risk in second generation devices. But what can you do in high risk patients whom you judge to have a very high thrombotic profile? Well, I think we have 4 possibilities. We can say, okay, I will continue DAPT until surgery. then you can do that. You can say, I will follow the guidelines of the ESC or the position paper and discontinue DAPT as recommended, or you can stop DAPT according to your gut feeling or clinical expertise. And what you also can do nowadays is that you can initiate bridging therapy. So this is the wonderful Pont de la Poya in Fribourg, for those of you who don't know it, and our cathedral here, Cathedral of St. Nicholas. So what does the expert position paper on the management of antiplatelet therapy in patients undergoing CABG postulate? So they say you can bridge patients with cangrelor who present high bleeding risk. This is class 1 indication, level of evidence B. That means it stems from one randomized controlled trial, which was small. You can see this here, 210 patients randomized, controlled, double-blind, and the primary endpoint was a laboratory endpoint. So they evaluated platelet reactivity by means of a point-of-care platelet function testing. There were no differences in CABG-related bleeding between the groups. However, in those receiving bridging therapy and in those receiving placebo. However, this trial is largely underpowered to evaluate such hard clinical endpoints. What also can be done is that you can bridge your patients with glycoprotein 2B3A inhibitors. There was also one study by Savanito and colleagues which evaluated in a single-arm manner tirofiban in 30 patients, and they had one case of TIMI minor and one case of TIMI major bleeding. So bridging therapy with cangrelor, which is also a P2Y12 inhibitor, so same mechanism of action, so the same receptor as thionopyridines. And this is how it could be done. This is a diagram who was extended or provided to us by Professor Pedrazzini, is what they do in Cardiocentro. When you see that in high-risk patients in whom you like to initiate bridging therapy, then you stop prasugrel 7 days prior to surgery, stop ticagrelor, clopidogrel 5 days prior to surgery, and you initiate cangrelor 2 days after stopping your dual antiplatelet therapy. You have 0.75 microgram per kilogram per minute, so it's a continuous IV drip. Then 1 hour prior to surgery, you discontinue your cangrelor and you reinitiate it 6 hours after the surgery. When you feel safe enough, so there's no more bleeding after CABG or after your surgery, and you feel safe enough to restart your oral P2Y12 inhibitors, then you can stop cangrelor and restart the P2Y inhibitors. This is the trial which I mentioned that discussed or that evaluated the effectiveness of cangrelor. When you can see here, this is platelet reactivity assessed by point-of-care platelet function testing, Verify Now. And so you see that after administration of cangrelor, there is a rapid decrease in platelet reactivity. This threshold here, or this cutoff point, should be below 240 platelet reaction units. It's an arbitrary endpoint. This is believed to be the threshold at which oral thionopyridines and ticagrelor are effective. And once you stop your infusion, platelet recovery is quite fast. Recovery of platelet function is quite rapid. And so these are the last guideline which I wanted to show you. In the expert position paper, they also recommend
you should probably come to your conclusion, because for the sake of time, you are very late.
Okay, no problem.
Thank you.
So we'll not speak about point-of-care platelet function testing, but I think management of pre- and peri-interventional antithrombotic regimen in PCI patients requiring surgery remains a challenging issue. Should discontinuation of oral P2Y12 inhibitors several days prior to surgical procedures is recommended by current guidelines, and I think it's reasonable given the excessive bleeding risk. And in patients who present with a high thrombotic risk, cangrelor, especially cangrelor, but also GP2B3A antagonists are efficient on a molecular level and a priori without conferring an excessive bleeding risk. But especially with regard to this and to the hard clinical endpoints in bridging, we need more data to accurately make inferences. Thank you.